Welcome, everybody. Good evening. I'm glad to welcome you to the first in a series of webinars on mental health and psychosocial considerations for gene therapies. My name is Tracy Heath Mondoro, and I'm the NHLBI Program Director for the Cure Sickle Cell Initiative. We appreciate having the opportunity to collaborate with advocacy leaders from the Sickle Cell Disease Association of America and the Sickle Cell Community Consortium, as well as members of the Cure Sickle Cell Initiative's Community Input Panel and the Patient Readiness and Resilience Working Group to bring this webinar to you this evening. By way of background, and for those who are not familiar, the Cure Sickle Cell Initiative is a program of the National Heart, Lung, and Blood Institute, which is part of the National Institutes of Health. Cure Sickle Cell is a collaborative, patient-focused research effort designed to accelerate promising genetic therapies to cure sickle cell disease. We know that mental health is of utmost importance to the sickle cell community, and we hope that tonight's webinar can help promote continued dialogue that can help us better understand your needs so we can address them as part of gene therapy trials. Tonight, we're going to be hearing from patients and providers. We're going to be hearing from Heather Avant from our Community Input Panel, from Dr. Marjorie DeJoie Brewer, from Beverly Francis Gibson, Dr. Stephen Hardy, and then we'll have a panel of patients and providers to discuss questions afterwards. Just a few housekeeping items. We will try to adhere to our schedule so there's enough time for questions. All attendees will be placed on mute during speaker presentations. Today's webinar includes a Q&A session, which will be conducted as part of our panel discussion. You may submit a written question during the Q&A feature located on the bottom of the screen at any point during the presentations. If your written question is directed to a specific speaker, please indicate that in your question if possible. We will make every effort to get to your questions during the webinar, but if we are unable to respond due to time constraints, we will follow up with you via the email that you provided during your registration. And please do not use the chat feature to submit questions. So first of all, I'm thrilled to introduce Heather Avant. Heather is the chair of the Community Input Panel of the Cure Sickle Cell Initiative. Thank you, Heather.
Thank you, Tracy. And thank you all for joining us today. I am super excited to present on the patient perspectives of mental wellness within the curative therapy. So I sit as the chair of the Community Input Panel, and I have been able to hear a lot of the voices from the community. And as a sickle cell patient myself, I have heard and listened and talked to so many patients and providers about what it is to have mental wellness through a curative trial and what it is to have hope. So when we first talk, we talk about managing hope, and we think about how do we manage hope going through a curative process, because there is this expectation amongst a lot of patients that you walk into the hospital on a Tuesday and you're cured on a Friday. And that is unfortunately not the case. So we want to think about what that looks like in regards to managing that hope and how communication is the key to success of managing the mental wellness of patients. As we know, that is very important. I have a friend of mine who is also a hematologist who often says to me, the body is easier to heal than the mind. So it's important that we are making allowances for patients while dealing with their mental issues. So it is, hope starts in so many places. As a sickle cell patient myself, I understand that hope is always with me, being hospitalized or not, being day to day. I live in a variety, in a world full of hope, and hope that I will be well, especially when I go into the hospital. But we need to manage that hope, okay? And how do we manage hope? Well, the source of hope comes from, I think, a lot of places, community. I think that's the biggest place that our hope comes from. The potential for changing locations can often diminish that hope, especially when a patient is going into a curative therapy. Sometimes a change of location is necessary. And there can be loss of community. I know for me, when I moved from Michigan to Texas, I lost my community. And there was a big change in my shift of hope. And then we also talk about loss of jobs or income and how that can affect someone's emotional well-being, as well as the effect that this thing and that hope has on caregivers and how those changes can affect the caregivers. And the caregivers are a really big portion of our mental well-being. They're the people who hold our hands when we are feeling ill and when the world seems a little bit too big. So we have to talk about the caregivers. And also in managing hope, we talk about the newest surroundings, adapting to new surroundings, what it looks like if you have to uproot your life and how that looks when you uproot your life for a curative therapy. After talking about managing hope, we have to manage expectations. That's the second part of the trial phase. Once you're in trial and you're going through transition or through conditioning and transplant, and conditioning is basically preparing your body. It's the marathon of curative therapies. It's the marathon that your body has to run. But also in running that marathon, your mind is running it as well, right? So it's important that we talk about what are those expectations going into a curative therapy. And there are, of course, always more questions than we have right now than answers, because this is a new area. We're breaking new ground every single day. So it's important to remember that questions are okay because we're hopefully working towards those answers. And it's important for practitioners to offer full disclosure as much as they're willing to offer and as much as they have to date on what the patient can expect, offering the patient a risk and benefit analysis. It's important that we allow patients to kind of fill out where they are within each step. And I know a lot of these procedures already are in place, but it's important that the providers and the medical team really stress these, because I know as a patient myself, there are times when those little instances of choice actually are missed. And it's very important that the patient have those faculties in place. And then providers need to be upfront and honest. And we say this and everyone's like, well, of course you want your provider to be upfront and honest. But I mean, I'm talking brutally honest. I know a lot of times providers oftentimes will skirt over small issues or major issues. And well, it'll be okay. It's all about listening. We come back to that key word of communication and having the providers seriously listening to the patient, hearing what they're saying in regards to how they're feeling mentally, emotionally, as well as physically. And then we understand that, and then there's the understanding to the patient, offering them understanding that sickle cell is a progressive disease. We're not curing the past, we're trying to cure your future. And it's a little bit of a disconnect because, you know, sickle cell being a progressive disease, there are things that can't be fixed, stroke, of avascular necrosis, blood clots. These things are progressive and they kind of stay with you. And unfortunately, sickle cell, because it's progressive disease, as we age, these things are more prevalent. So, you know, I love the children and I love the idea of children going into curative therapy because it's starting them when they're young is the time to start them out on this process. But I know that there are people who are my age, or close to my age, who would love to go through a curative therapy, who are chomping at the bit to participate in something like this. So it's important to think about those progressions and that the body, that wear and tear, unfortunately, at this time can't be reversed. And then we think about acceptance of a transplant. There are some patients out there who just need to have this happen. And it needs to happen quickly because they are that ill. And these are last hopes. And how does a patient accept that I'm going to go through this process that's still under trial? And it's all about the providers and the medical team really sitting down and talking to the patient about these things. And then what the patient can expect. And I have on here 1, 5, 10, 15. We do not know all of this just yet. You know, these are things that we are hoping to learn and gain an understanding. But we want to say best guess scenario. What is the worst possible scenario? What can potentially happen in my life? I think it's important as patients that we understand those. And then we talk about managing expectations. This is the end. This is, you've gone through the conditioning and the treatment. And now we're talking about managing expectations. What can I expect from my trial? Well, there are adverse effects, and I'm not a doctor, so I'm not going to go into these too deeply, but there are some adverse effects: sterilization, secondary cancer, PTSD, transplant failure, and death. These are definitely adverse effects. But the thing is it's the goal not to scare the patient away, but to be completely honest that adverse effects do happen. But I really want to focus on identity issues. This seems to be a reoccurring theme amongst the community. I've heard it over and over again that patients are afraid of losing their identity because so many sickle cell patients identify as, I am a sickle cell patient, because for so many of us, it has taken up a huge portion of our life, in and out of the hospitals, in and out of doctors' offices. And that is identity building. So it's important that the providers understand that since sickle cell has been with this person for life, how do we counteract those thought processes of that person potentially losing their sense of self? And then there's stigma within the healthcare system. I recently talked to a patient who's undergone a curative therapy, and I believe they said, well, I don't know where I fit in anymore because I'm a cured sickle cell patient. And I don't really have an identity anymore. Where do I fit in the healthcare system? When I go to the doctors, there's no coding for me. I still have issues, but I'm no longer a sickle cell patient. And it was a hard adjustment and a hard frame of mind. So we have to remember to think about how can that affect someone's mental health, going through the medical system and almost being lost and not really having a space to go to. And then dealing with anxiety and depression. Something that I think a lot of sickle cell patients in general have experienced in their lifetime. Many of us have gone through anxiety and depression. I know for a fact that I have myself gone through anxiety and depression. And I know that it has been helpful to have medical providers who are my family, who have created relationships with me to listen to me, where I have been allowed to break down in their office and tell them how angry I am about how I'm feeling in my own skin. So it's important that we have that connection as well as continued communication, and not just talking, but listening. And then there's survivor's guilt. And we talk a little bit about what it's like once you're a sickle cell patient and you're cured and someone else passes away from sickle cell. It is a very hard road to go down. Most sickle cell patients have experienced a loss of a friend who has had sickle cell disease. And it is one of the hardest things to have to go through because you face your own mortality. And I could only imagine how that is once you're cured and how that is. So we need to be mindful of their mental state. And then watching your friends get sick and ill, and how that plays on your heartstrings and how that plays with your mind. And then also, again, I return to caregivers and friends and family having survivor's guilt. I know that this happens in a lot of families who have sickle cell patients, the parent or the loved one who says, why not me? And why did I do this? So we have to think about it. It all comes back to advocating for the patient during this time and always, remembering that it's not always the job of the patient to advocate for themselves, and that sometimes we need those champions of healthcare to advocate for us and for our mental and for our own mental health. It is so, so important. As I fumbled the ball. So finally, I come to the end of my little presentation, and I want to talk about some resources out there. If you are suffering from anxiety, depression, or suicidal thoughts, there are resources out there. Reach out to your medical providers. There's some links here listed. Reach out and get the help that you need, because we're all in this world together, this sickle world together. Thank you so much, and I appreciate your time.
Thank you so much, Heather. As we move on to the next portion, I just want to say again that we're so pleased to partner with the Sickle Cell Disease Association of America, as well as the Sickle Cell Community Consortium. And we timed this webinar at the very end of September, which is Sickle Cell Awareness Month. and also to serve as a bridge between events that were sponsored by both of these organizations. In August, we had the Sickle Cell Community Consortium convention, and we look forward to the SCDAA convention in October. And so with that in mind, we've worked with the advocacy community to have representatives to speak to you about what the different organizations are offering. And so next we're going to hear from Dr. Marjorie DeJoie Brewer. I'm going to get it right the next time. She's the medical director of the Philadelphia, Delaware Valley chapter of Sickle Cell Disease Association America, as well as Beverly Francis Gibson, who is the president of the Sickle Cell Disease Association of America. And they're going to talk to us about the different organizations and how they're working, how they have mental health initiatives and how they're working with the patient community on mental health issues. So I will turn it over to Marjorie. Thank you.
Thank you so much, Tracy, for that. So good to be with all of you this evening. So just a slight correction. I am the medical director for the Sickle Cell Association of Delaware. And I'm so pleased to be with you, all of you this evening, as a member of the Mental Health and Wellness Initiative for the Sickle Cell Consortium. And I have the pleasure of sharing some insights with you, building on what Heather has already shared, that the organization and the community at large is doing. So there's been a progression in the Sickle Cell Mental Health and Wellness Initiative and its primary objectives, and connecting with the community in drawing that timeline. And we've seen how that progression has evolved over the past couple of years, starting in 2016, where the sickle cell patients themselves and caregivers and CBOs prioritized the need to increase that awareness and increase destigmatization, of mental health and support for mental health issues and concerns. It grew into launching the Mental Health Initiative and began monthly presentations, which then evolved into recognizing the needs for additional mental health support and starting partnerships with STAR and Be the Match to create enduring materials and curative therapies. Mental Health Initiative then expanded into mental health and wellness, because we realized the importance and the partnership of those two in 2022. And then most recently, the curative therapies, the good, the bad, and the ugly. And I think it's really important to show that progression because it shows how vested individuals are, patients, providers, community leaders, in the importance of mental health and wellness within our communities. Also, what's important are the venues in which we share them, the communications through different forums. So set up systems through the Sickle Cell Consortium where formal webinars are done with psychologists and mental health providers, small group chats, partnered with Be the Match, as I mentioned before, to offer specifically one-on-one counseling and support for warriors, and warrior games. As we know, there's never one size fits all, right, for any issue, and that we want to be able to provide these resources in different platforms for patients so that they are comfortable and they can be engaged. So there were some profound insights that came from the community in that curative therapies. And Heather hit some specifically that I wanted to highlight that I'm gonna restate actually. The one was the fear of the life without sickle cell disease. Are we ready to have that conversation? Do we front load it when individuals are going into curative therapies? Patients unaware that there are actually formal mental health support systems. As a patient myself, as a warrior and a provider, and going through the process for a potentially curative process, not being part of the NIH program, I was struck by how there was a lack of support. And so having that as part of the entire therapeutic regimen and process is extremely important. Caregivers worry about not only the overall health, but how their child will change and whether or not they are doing the right thing for their children. And it's important that we address these issues up front. And one cannot ignore the external impact. Though information sometimes delivered in venues that we hope are positive, they have repercussions and they impact our patients going through these curative therapies. So that these issues should always be kept top of mind and different formats should be used in order to address them. So what are we doing looking forwards through the Sickle Cell Consortium, right? The Mental Health and Wellness Initiative has included and added an increased focus on mental health challenges related to curative therapies, specifically in sickle cell disease. Ongoing and new plans include community presentations, community conversations, panels, and roundtables. Evening wholeness, including yoga, breathing, mindfulness, and mental health checks. Curative therapy town halls, and Warrior University series. Vitamin SC3 podcast to include monthly mental health discussions. Again, trying to reinforce that mental health message through different avenues. And resources that are available are the Mental Health Sickle Cell Classroom and the Mental Health Wellness website. It was a pleasure being here to present some of these insights with you. And I'm going to pass the mic on to my co-chair in this particular segment for Insights, Ms. Beverly Francis Gibson.
Thank you so much, Marjorie. It is always a pleasure for me to do anything with you, so I actually appreciate that. And I do want to thank Tracy and the Cure Sickle Cell Disease Initiative for having SCDAA as part of the conversation this evening. I want to focus on a number of things that we're doing at SCDAA. And for those of you who may not know about the organization, I just thought it would be important to just provide a backdrop. SCDAA was created back in 1971, and we serve as the nation's largest sickle cell disease focused organization, hoping that one day there will be a cure for sickle cell disease. And we do that by encouraging our 53 member organizations to work in partnership with us. And we also work with the community and other groups also to spread our message. It is important that people who are a part of this conversation today understand our mission. You know, we really are focused on ensuring that all people living with sickle cell disease, warriors, patients, caregivers, family members, and the larger community understand the impact that sickle cell disease has, not only on families, but on loved ones and on the individual living with the disease. I wanted to also share with you some of the things that SCDAA, as we are affectionately known, is also providing in terms of services and programs. We have a community health worker program, and we're training individuals who are interested in becoming community health workers on how to do that in their local communities. And that curriculum does include some mental health and conversations about how to interface with patients and families who may be facing those types of issues. We also have a peer-to-peer mentoring program that is designed for a transition. And so we pair a mentor and a mentee, 18 to 24, to help with that transition period and provide a network, a coach, and a buddy, if you will, to help them with those issues. I also wanted to share that we've had a number of webinars, town hall meetings. We actually just hosted one on Monday of this week on gene therapy. And so the conversation is continuous. And I think it is important that all of us, as I've said before, are continuing to work together to do so. Our annual convention is coming up in October, as Tracy said, it's the 12th to the 16th. And we actually have a number of sessions that will be focused on mental health. And we actually have warriors who are participating to discuss their experiences with mental health concerns. Additionally, I also included some information about things that we had heard from the community during COVID about how they were coping with the pandemic. And I'm not going to read this entire list to you, but we did hear about increased levels of anxiety and depression, isolation, hopelessness, and just fear, not knowing what to expect and what was going on in our larger community. And I think what we've tried to do through SCDAA and our medical research and advisory committee is to address those concerns as they have been brought to our attention. Also, I think, as I mentioned, our convention is coming up, and we hope that you will join us and register for that. On the next slide, I have a listing of the topics that will be covered. And we do have, as I said, a number of sessions focused on mental health and psychosocial concerns for the larger community. Tracy, I want to thank you and the team for having me be a part of this presentation today, and I look forward to the conversation.
Great. Thank you so much, Marjorie and Beverly, for that. So our next segment is devoted to, there's a subcommittee within the Cure Sickle Cell Initiative, the Patient Readiness and Resilience Working Group. And I'm pleased to introduce Dr. Stephen Hardy, who is the chair of that panel. Stephen is also a practicing psychologist at the Children's National Medical Center in Washington, D.C. Welcome, Stephen. Thank you.
Thank you so much. It's such a pleasure to be here this evening to tell you a little bit about our Patient Readiness and Resilience Working Group that's a part of the Cure Sickle Cell Initiative. I feel really fortunate to have a chance to represent our members, which is just a fantastic team with a lot of great expertise and insight. So I'm happy to represent the work that we've all been doing together. So I thought I would begin by telling everyone a little bit about the origins of this working group and why we exist. And to me, it really begins with some recognition that deciding to participate or not participate in a clinical trial for genetic therapy is not a simple decision. It's actually extremely difficult and probably one of the hardest decisions that people will ever make. There are a lot of questions that could come up surrounding a decision like this. Is it safe? Will I be able to have kids? What do I do if my family doesn't agree with my decision? And there's also some recognition that psychosocial factors will influence someone's readiness for genetic therapy, and that genetic therapy itself and the outcomes of that trial will affect a person's psychosocial well-being, not just in the short term, but also in the long term, with serious implications for someone's mental health. And there are some important questions that we have to try to answer. So we need to be able to answer questions like, is the patient ready? What supports are needed? How to ensure that the trial proceeds safely and ethically. And from a few different perspectives, I think we probably have some good answers to these questions. So a lot of specialists have good ideas about how to address some of these concerns, but some of the areas where we feel like maybe there are more questions than we have answers are around the cultural issues, spiritual issues, social issues, and psychological issues that we really need to know more about to make decisions about whether or not somebody is ready, or what types of supports are needed, or how to make sure that the trial proceeds safely and ethically. So the purpose of our working group is really to bring together a group with expertise in psychological aspects of sickle cell disease and engage with the patient community to identify and prioritize key psychosocial issues that should be considered when conducting genetic therapy clinical trials. And the types of activities that we were charged to engage in are identifying and raising awareness about key psychosocial areas that are relevant to genetic therapy in sickle cell disease, drafting best practices for assessing trial readiness, reducing potential for harm, and promoting positive psychosocial outcomes following genetic therapy, and lending support to the development of funding opportunities and educational materials related to psychosocial issues in genetic therapy for sickle cell disease. And as I mentioned before, we've got an amazing team that's working on all of these activities. So just wanted to share Clayton Andrews, Dr. Sean Bediaco, Dr. Lori Crosby, Dr. Charles Jonassaint, Dr. Jerlyn Porter, Maria Rivera, Dr. Sumetry Sill, who you'll see a little bit later, and Dr. Cecilia Valerie. So again, this is just a fantastic team, and I'm really proud to be able to work with this group to address some of these issues. And so just to share a little bit about our progress to date. So we have been around for about a year. We meet monthly remotely, and had our first meeting in September of last year. We've been soliciting input from patients and community organizations and other stakeholders about what they feel are important psychosocial considerations, reviewing existing scientific literature and other professional documents and other models that are used in different populations. And then we spent some time identifying guiding questions that would help us figure out where we should be going with this and what type of framework would be helpful for developing best practices for institutions. We've had multiple small group writing meetings to work on these best practices and expanded our membership just in June this past year. And I wanted to share some of the things that we heard from some of the subcommittees within the Cure Sickle Cell Initiative that's helped to inform some of our thoughts around this. And so some of the things that we've heard are that clear information and transparency is needed about possible risks and consequences. Investigators need to help foster realistic expectations. So these are things that Heather was mentioning earlier as well. It could be helpful to provide therapy or counseling before the trial, and signing informed consent doesn't mean that somebody is prepared necessarily. A patient's history of mental health concerns needs to be considered. There needs to be a focus on mental health throughout the course of the trial, so not just at the beginning while they're in the trial or after the trial. It needs to really cover all of those phases. And also some recognition that there are often external social stressors that have to be considered and addressed. We also heard that it would be helpful if education about the trial came from the person leading the trial, the doctor leading the trial, but that it should also be supported by other members of the team, and that social workers are a really important part of the team across the course of treatments. But we also need to consider that not all institutions may have the same level of resources to provide that type of support. But it's important to engage the entire family, especially with younger patients, so not just looking at individuals within a bubble. It's important to proactively address barriers and mistrust and not wait until those become serious issues. And patients need educational materials that are not sponsored by industry and appear to be impartial. And there's also a need for indefinite follow-up. So how somebody is doing immediately after the trial may not tell you a whole lot about how they're going to do a year later. And so there needs to be ongoing monitoring and support provided. So I also mentioned that we did a review of the literature and some other documents. As you might imagine, there's not a lot of literature to really guide us in making or drawing conclusions about readiness and resilience and mental health outcomes of genetic therapies. But some of the things that we did see was that there's evidence that a lot of individuals with sickle cell disease say they have limited knowledge about gene therapy and they have worries about chemotherapy and other risks. There's a study that showed that older patients say that they're more likely to consider gene therapy compared to younger patients. Although I've also seen a study that said the exact opposite, and older patients are actually less likely to consider. So I think there's more to learn there. And another study showed that primary caregivers of children with sickle cell disease view gene therapy as a potentially less risky treatment option compared to stem cell transplant. In terms of the mental health outcomes, I think there's really not a lot to go on at this point, but we can perhaps draw a little bit from other therapies like stem cell transplant where we know a little bit more. But initial data do suggest that there are improvements in some aspects of quality of life following gene therapy. There's some evidence that we see reduced pain intensity and pain interference with daily activities, as well as lower anxiety and depressive symptoms and fatigue. And some have said they viewed improved satisfaction with their social roles and physical functioning. I also want to point out the National Academies of Sciences, Engineering and Medicine put out a strategic plan and blueprint for action on addressing sickle cell disease. And this quote that I have here is actually related to stem cell transplant, but I think it's still relevant to point out that this group, who put a lot of effort into developing these recommendations, said that even stem cell transplant carries a high psychosocial impact, and care that addresses the psychological and social factors should be a standard of care, beginning at pre-transplant all the way to post-transplant and long-term follow-up. And they also acknowledge that gene therapy is advancing very quickly, and there's a need for education and patient-facing materials on the risks and benefits, including the long-term implications of gene therapy, which I think we're still learning about. I also just wanted to highlight that considering the role of mental health in the context of big life decisions and big treatments is not new, and it's not something that's unique to gene therapy, but it's something that a lot of other treatments and populations have focused on, and to some degree we're behind the curve a little bit and need to catch up, but I think there's a lot of precedent that this is an important thing to do. So here I've highlighted, you may not be able to see this, but this is from an article about solid organ transplant and some guidelines about supporting mental health. And they say the psychosocial issues surrounding transplantation affect the ultimate success of a transplant. And I think that that's a really telling statement, and probably true for sickle cell disease and gene therapy as well. But there are other examples where mental health has played a key role in, and it's really integrated within the treatment itself, and something that we should be thinking about. And so getting to our guiding question, so what have we been focused on really as a working group? And the question that we've focused on is, if a person with sickle cell disease chooses to pursue a genetic therapy trial, what level of psychosocial support should be provided by an investigative team and institution to minimize psychosocial harm and optimize benefits? And we see this as something that needs to be considered at each stage, before gene therapy, during the trial, and after gene therapy. And for now, we've been focused just at the beginning stage. So what are the psychosocial considerations before the trial begins? And to do that, we're looking at best practices for assessing knowledge and readiness for gene therapy, and best practices for assessing psychosocial risk and protective factors that might tell us something about what level of support a person might need during the trial. And so I apologize, I know this is way too small for anybody to see, but I'll try to walk you through it a little bit. So this is just a draft model of how we're sort of thinking about the role of incorporating evaluations of patient readiness and resilience. And so we sort of view this as beginning with an institutional self-assessment, where the hospital or the investigative team pauses and says, do we have the capacity to support someone's mental health in an adequate way? And if they don't, then that's okay, but we need to think about what are the corrective actions that need to be taken to make sure that you can adequately support somebody's mental health before even beginning the trial. But then it moves on, once you feel comfortable with that, to patient preparation, where you're introducing the idea of the clinical trial to a patient, at which point somebody may say, nope, not for me, or they might be express interest, and then you go on to provide more careful and planned and repeated conversations and discussion about what it means to participate in the trial, and giving opportunities to ask questions and get those answered. And not just a one-time discussion, but multiple discussions. Whenever that feels like those discussions have happened, then moving on to this evaluation of patient readiness and resilience, where I'll outline in a second sort of what that may look like, but really an opportunity to pause and have a conversation with a psychosocial provider to try to evaluate what are the gaps, or what are the needs that we need to do a better job of supporting patients in, so that they feel comfortable moving forward if that's what they decide to do. And we imagine this being really a discussion or a clinical interview, but it could be supported with things like cognitive testing or questionnaires. But it should be viewed as informational, both for patients and the investigative teams, and really used to guide delivery of supports to enhance patient readiness. But and a really important point, though, is that we wouldn't ever imagine this being used in some way to pressure or persuade somebody to do something that they don't feel comfortable doing, nor should the findings of an evaluation like this ever be used to permanently exclude somebody from getting the type of treatment that they want and need. But so this would involve gathering information about a patient's understanding and how they feel, how ready they feel to proceed with the trial, encouraging open discussions about and concerns about genetic therapy, providing an overview of psychosocial factors likely to influence the trial, looking for patient strengths that can be leveraged to really promote and support and build up their psychosocial well-being before, during, and after the trial, and identifying risks that need to be considered and addressed through education or psychosocial support or other community resources that are available. And then whenever everyone feels comfortable and feels supported and like there's a good plan in place, at that point, you would then move to informed consent. And so just to wrap up, just talk a little bit about our future plans and recommendations. So right now we're working on finalizing an initial draft of what this assessment may look like with some supporting documents that could help to help institutions to implement these best practices. But we'll also be having a period where we'll solicit feedback from the community and patients and caregivers and advocates and other subcommittees and stakeholders within the Cure Sickle Cell Initiative, so that we can make sure that we're not missing anything and make sure that we can address any concerns to make sure we have the best document possible. Also developing those support documents to help sites implement any of the best practices that they feel able to do. And then moving on and thinking about beyond the pre-trial phase, what sorts of psychosocial supports and considerations really should be a standard of care during the trial and after the trial. The working group is looking for ways to be a resource to other groups within the Cure Sickle Cell Initiative and other opportunities to enhance collaboration with the other groups and within and outside of the Cure Sickle Cell Initiative. So I just want to acknowledge again my fantastic group of colleagues that have really helped to make all of this possible. The community input panel and research coordinators, committee members especially, who gave a lot of the feedback that I shared earlier about guidance and what we should be thinking through. The Cure Sickle Cell Initiative leadership and the MS company for their support in making all of this work possible. So thank you so much.
Thank you, Stephen. So without further ado, we're going to move to our panel on psychosocial considerations for gene therapy trials. And the panel will be led by Dr. Victoria Coleman-Calgar. Victoria is a member of the executive committee of the Cure Sickle Cell Initiative, and she's also a clinical psychologist. So thank you, Victoria. I'll turn it over to you.
Thank you. Thank you, Tracy. Our panel this evening is very exciting. We have providers, we have caretakers, sickle cell disease curative therapy trial participants, and those living with sickle cell disease who have considered participating in gene therapy trials, all discussing the psychosocial considerations involved with their decisions. And so I just wanted to thank the panel members. We're so grateful to have you here tonight. And before we get started, I'd like to ask each of you to introduce yourselves and share one thing that played an important role in your sickle cell journey as it relates to mental health. And it may be something that you knew, something that you wished you had known, or just something that you think is important for other people to know. So we can go in alphabetical order and start with Clayton.
Hear me? I just unmuted myself. I want to make sure I can be heard.
Yes, we can hear you.
Awesome. Okay, so I'm Clayton Andrews. I just had a birthday. I'm 39 with sickle cell. So that in itself is a blessing. I am a licensed professional counselor, mental health professional, clinical supervisor, and I am also a sickle cell patient. I think for me, really, it's just my passion for advocacy towards sickle cell and my passion towards mental health just merged into one. That kind of is the driving force for me.
Great, thank you. And moving on to Maria.
Hello, everyone. My name is Maria Rivera, and I have been a sickle cell advocate for the past 25 years and a half that my daughter lived. I lost my daughter to a bone marrow transplantation almost 3 years ago. So adding that to the 25 and a half, I'm almost like on my 30th mark advocating for sickle cell, and also I'm part of the staff for the Sickle Cell Community Consortium. I love what I do. I love to advocate for all these people and put my little grain into the conversation, my experience that all the things that I've learned when my daughter passed away through going through the bone marrow transplant. I think this made me a better person because, first of all, I did not expect that I was going to lose her. And so it was kind of difficult. And it's still difficult for me, but I'm trying to help as much as I can, all of my community members. And so if I can do something for them, I can tell you what I went through and all my experience. And one thing that I will not change was I was not born to be a mom of a sickle cell patient, but I learned with my patients to be a good human being, and I learned as quickly as I could, and I'm still learning. So thank you for the invitation. And one thing that I will not change is that I'm still advocating for all these people, and that's pretty much it. I'm still here for each and every one of the warriors that need. Thank you.
Thank you. And we appreciate that you're here and that you could join us and for your perspective. Dr. Sumetry Sill.
Hi, hi everyone. I do want to say a sincere thanks for Cure Sickle Cell Initiative and SCDAA and Sickle Cell Consortium for pulling this together and offering this to the community, which is really wonderful. I am a clinical psychologist at Children's Healthcare of Atlanta, and I work primarily in the Cancer and Blood Disorders Center there. And in my work in working with children and adolescents with sickle cell disease and their families, you know, I see and hear from them their experiences of the range of emotions that they experience and go through related to their disease and their treatment options and the efficacy that they feel with their treatments and these choices that they are offered in terms of their possible treatments moving forward, and the impact that that can have on not just the individual with sickle cell, but everyone in their family and their social support network. And so it is a privilege to be able to support them in the ways that we can, to be able to help them live their best possible lives, both physically and mentally in a good space.
Wonderful. Thank you so much. And last but not least, Tiana Wolford.
Hi everyone, my name is Tiana Wolford. I am 30 years old. I have sickle cell genotype SS. I went through a bone marrow transplant and rejected about 11 years ago. I am recently the CEO and founder of the Sickle Cell Reproductive Health Education Directive, or SCRED for short, which is the first and only organization to solely focus on the reproductive health of sickle cell warriors, which had a lot to do with my experience with infertility after the transplant. I'm excited to be a part of this conversation, and I think one of the things I wished I had known when I was younger is that your mental health is just as important as your physical health. I think reflecting back into my middle school, high school years, a lot of my crisis were really brought on by stress and anxiety. And I think maybe if I had learned better coping skills earlier, that would have prevented some of my hospitalizations.
Thank you. Yeah, that's a powerful message, and appreciate you sharing that. We have a variety of perspectives, which should make for a great conversation. So I'd just like to start with the idea of preparing for a curative therapy trial. And Tiana, we'll start with you, and other panelists can join in the conversation as well. What goes into a person's decision to participate in clinical trials, and how does that, how does their mental health impact those decisions?
Yeah, thank you for the question, because a lot of times when I share my story, I kind of start off by saying that a lot of my decision to go through with the bone marrow transplant had to do with my mental state. And I really made that decision from like a defeated and depressed state, which I don't think is where you should be when you make this decision. I just felt so defeated from some of the physical implications of sickle cell. And I think the harm that that did is, like, when I was going through my consultation and my informed consent process, even when they were going over the risk, I really wasn't hearing or retaining any of that because I was just so focused on the cure. And I think that it's important what's already been shared about managing expectations. There's a lot of conversations around, you know, like life after transplant if you're cured, but not a lot about if you reject or if it doesn't go your way. And so I think that, you know, the mental health plays in even just from the decision-making process. And there's kind of this area of gray with sickle cell that you don't have in the oncology world about when to do it and all of that. And I think that your mental health really plays a decision even in just deciding to go through with it.
Mm-hmm. And you mentioned not hearing risks, and I'd be interested in hearing more about your thoughts on what might have helped you hear risks at that point, or others that have been through that situation, or from a clinician perspective, what have you found that helps people to better hear what those risks are?
I think that maybe if there had been like a mental health specialist walking me through that and having conversations about life after and risk benefits, but also I think that there's so much value in the patient voice. And I think that anyone who's going to be going through a curative therapies would really benefit from hearing from patients, because while providers can provide the medical perspective and the mental health, they can provide the insight into the psychological aspects. I think that it really goes a long way to hear from people who have been through it.
That is very important. And Dr. Sill, did you want to add anything to that from your perspective?
Yeah, I think Tiana made such a great point about connecting with other individuals who have gone through transplant or genetic therapies and who have had maybe different experiences, right? So maybe their outcome was similar or not similar to what they were expecting, so that in that conversation of risk, you know, a professional or provider can also talk with them about what it could look like from all sides, right? Like, how would this look if it went your way, and what does success mean to you, and what's everything in between? You know, what would an unsuccessful outcome look like, and what are all of those different aspects? And I wonder if that might be one way to be able to then, you know, integrate the potential risks in different scenarios. And if that repeated kind of conversation in shorter, you know, durations might be something that would help people receive that message a little bit easier.
Mm-hmm. And Maria, as a caregiver, what was your experience like with, you know, hearing about the risks, and did you feel like there was enough discussion, or did you feel that more of your voice or others' voices needed to be added to that discussion?
In my experience, I think I always think about time. I wish we had more time to be able to review all the book that they gave us. It was a 300 pages book, but it was all related to leukemia and cancer, nothing related to sickle cell disease. And I wish I would have said something at that point, but I did not. My daughter was very enthusiastic about receiving the transplant, and the night before she went through all the process, and she was admitted to a hospital to do blood exchanges, get the line on the chest because he got infected and so many other complications. She wanted to say, no, I don't want to do it. And I was very impressed that we did not have nobody, we didn't have nobody counseling and saying, I'm here for you. Are you feeling okay? Are you still ready to go through this? Do you still want to do it? There was nobody there for us. So one thing that I would like to always emphasize is that if anybody wants to go through the process, they do need a group support before and after the process, because you have the patient, you have the caregiver, and that's it. And then a whole bunch of doctors and nurses and students and whatever else wants to come in. And you feel lonely pretty much. You don't feel comfortable to the point where you can say something, where do I go? Where do I follow up if I don't want to do this anymore? Nobody can answer that question. And there is still time to say, no, I'm not comfortable with what you're doing. I don't want to continue the process. And you know, it sounds harsh, but it is the truth. I wish we had support.
And Clayton, in your experience, what type of support have you seen people wanting or felt like needed to be given in order to manage expectations or to deal with the risk?
I honestly think it's just like everyone else said. You need a team. You need someone from each discipline. If it's a social worker, the therapist, psychologist, everyone that comes together that can help educate and support the patient. It all, you know, it's one of those things that just, it all fits in.
Okay. Yeah. It's so important to, everything that's been said is vital in order to have a successful experience pre-trial, but then also going through during the trial and after the trial. And I'm curious, do you feel like this needs to be a part of just considerations of mental health? Does it need to be included in clinical trial design?
I feel like it does, because if you're doing a clinical trial design, you want to factor in everything that's necessary to make sure you get it right. You know, you measure 10 times to cut once. So when you're preparing, you look at all these different areas, you look at what supportive factors might be needed, what educational factors might be needed, what mental health factors are taking place. You know, if we're dealing with our physical health as well as other mental health issues, we need to take that into account as well to be able to factor everything in to make things work.
And so what is your reaction to what Dr. Hardy presented in terms of potential recommendations and considerations for clinical trials?
I feel, well, I agree. I mean, each of those areas is necessary. I'm trying to think of where I can, so I used to work with defects, and working with families, we had multidisciplinary team meetings. You had the family, i.e. the client, i.e. the patient. You had the case manager, i.e. the doctor or the physician, and you had everyone that played a part. You had an advocate, you had the social worker, you had doctors, you had everyone that had these views. And the most important thing in there as well was it was a case plan centered around the client. So the client more or less, I don't want to say dictated, but directed how they wanted things to proceed to help them benefit.
Others have any thoughts?
I would also maybe add that I want to circle back just a smidge and reinforce what Maria said about consent being an ongoing process. And it's not that you consent once and then that's it, but that it is an ongoing process that people are allowed to change their minds. And I think related to that, when thinking about trial designs and mental health and how that integrates. I think the key point that needs to be considered is, assessing and understanding what factors are at play for that individual or for that family, and really trying to boost up as much resources and support around their individual needs as possible. And that's going to vary from institution to institution, because, not all places will have a caseworker and a social worker and a psychologist and a psychiatrist and wonderful nurses that you feel very connected to, and a team of, providers. So I think working within the system of what is available, but then also reaching out to the community and finding those resources so that individuals with sickle cell don't have to do that on their own, that they'll have those resources available to them, so that when those mental health needs are identified, that they can be connected with the support and resources that they need. And that should not exclude them from being able to proceed with a gene therapy trial, but they really do deserve the opportunity to, get the support that is needed so that they can be as successful as possible throughout the process. So I think it's that linkage piece that maybe we could really try to help, support the systems the supports that are available within the system, but then also really drawing upon our community work resources so that all of our patients are getting the services that are required.
Yeah, and that's a really great point that resources may not be available at each site, the same resources. So working with what you have, I think, is really important, and linkage to the community is really important. Patient voices and communication is really important. Are there other areas of kind of priorities for mental health where you see those being the major concerns? Like, what are the major mental health needs that someone might have coming in for curative therapy?
Well, I kind of have something. I think that one of the things for me, and I know that there are a lot of families who go through this when they're way younger. I was 19. I think that, we have to have more conversations about fertility after transplant and curative therapies, because I think that, I get calls from a lot of families of 7-year-olds, 13-year-olds who are saying that they don't want children and they'll be okay if they're not able to. But for me, making the decision at 19, the way that the transplant was presented to me, it was kind of like more about survival and let's just focus on keeping you alive rather than worrying about children right now. And I thought that that was an okay trade-off, but reflecting and I rejected and being infertile, I learned that that's not a fair trade-off for anyone. So when we're having a conversation about resources, I think that it has to be a shared responsibility that we make fertility preservation more accessible to the sickle cell community in the way that it is to the oncology population, because I can say that from personal experience and from what I hear from the community, that's something that plays a lot into the mental health with these curative therapies.
Mm-hmm. And in terms of resources and educational materials that are available, do you feel like there is a need for more?
There's definitely a need for more. I remember 11 years ago going to Google, looking up resources for fertility preservation, and everything was for cancer. There was legislation in place, there were resources, there were grants, and there was nothing for sickle cell. And it was incredibly disturbing when I did the same Google search last year and found that we were in the same place. And that really has a lot to do with why I started my organization along with Dr. Lydia Pecker and Dr. Kim Smith-Whitley. It's turned into an amazing umbrella of reproductive health, but that's one of our highest priorities, is more resources for fertility preservation, especially for warriors who go through curative therapies.
Mm-hmm. And I think we can just talk a little bit about one more issue before moving on to Q&A. Maria, what are some real world best practices for assessing psychosocial risks in gene therapy trials in your opinion?
In my opinion, and let me see if I'm on the right track, there's a lot of considerations that need to be added to this type of therapies. For instance, I thought I knew everything and I had everything ready for my daughter because we say I'm the caregiver and I'm ready for this, but you do need a lot of support as a caregiver and also as a patient. And again, family is not close to my area, no friends because we cannot keep up with friends. So I always complain about the same situation. If I had a psychology, a therapist, a counselor guiding me the way I needed, I think it would have been a lot better because in between all this, they talk to you. The first thing they bring you is the financial department. In my situation, in my experience, we had insurance at that time for Jasmine, but the insurance doesn't do transplants, so they don't cover for that. We have to have in consideration, besides having mental health practices and effect group therapies and all that stuff, we need to know where the money is going to come from. We need to know transportation, how many appointments are coming after the transplant. And if we as caregivers, are we going to be able to handle all this situation, the before and the after, for how long, for how many years? They don't tell you all that. But again, this was my experience at another place. And I don't know, maybe things are going to get better. They told us they had, I questioned them, how many transplants have you done? I didn't even know the word conditioning existed until I worked with you guys. So things are different now, you know, but we have to mention myself, especially as a caregiver for my daughter. She's gone, nothing is going to bring her back. And we need the support, major support from the family members, friends, and whoever else is available, social workers, caregivers, and again, not only for leukemia and cancer patients, as a sickle cell patient that know what we're getting into.
And I just want to say I'm sorry for your loss, and your story, I think, just highlights even more why consideration of mental health and other psychosocial issues as well is so integral to clinical trial design and to the work that's being done, curative therapies. All right, so at this time, I would like to start the Q&A session. Please use the Q&A feature at the bottom of your screen to type your questions into the text field, and you can hit send. The first question I see, in what ways might the role of mental health stigma play in the integration of mental health services into patient care? And presenters or panelists, feel free to answer any of these.
Can you say it one more time?
In what ways might the role of mental health stigma play in the integration of mental health services into patient care? Like the role of stigma, I think, is what it's coming down to.
How would that play into the patient care?
Yeah, when you're integrating mental health care with kind of traditional patient care, what role does stigma play?
I guess I'll go first. I feel like it might depend on the patient. It might depend on the social upbringing, the familial upbringing, what are the beliefs, what are the practices. You know, for instance, in the Black community, somebody says they're getting therapy. Oh, you crazy. Oh, you got some issues, or something wrong with you. And that's that's one of the biggest stigmas in the Black community, mental health and seeking that care. So if that is something that we're already pursuing something medical, that's a major issue, that's a major deal, and it's stressful enough. And then we start to consider the mental health and wanted to get the mental health and get the help. but that stigma, that stressful stigma behind it, that could interfere in some of the processes.
Yeah.
Oh, sorry, go ahead.
I was just gonna agree with what Clayton is saying. I think this is a really important issue to consider that could create barriers for people. I will say that in my experience, sort of the way that mental health is introduced to people can really make a difference. And so I think, you know, it's in some of the patients and families that I've worked with, it feels a little bit more acceptable and a little bit more normalized to meet with a psychologist who is really viewed and presented as being part of the medical team. So just in the way that you're going to go meet with the pulmonologist and you're going to go meet with the neurologist, you're also going to meet with a psychologist. And you know, I think the times where I felt that stigma about mental health really became a barrier, it was sort of like their provider recommending that they go just to see a psychologist to get some help. And I think in some ways, having this type of mental health care embedded within the trial or within the medical team, at least in my experience, has felt like it's been a nice way to sort of access that type of support that may be more challenging otherwise.
Thank you. And here's another question. Well, amazing presentation. It really resonates that there wasn't enough support to readdress concerns once complications occur. I would love to hear from the panelists once they were in the middle of a transplant, i.e. past the point of no return, what supports helped or what supports were lacking when challenging complications occurred.
Well, I think for me, mine was 11 years ago and it was kind of early on and it was a haplo transplant. And, you know, the sickle cell community, we're really close knit, kind of small, but there's not a lot, especially at the time when I did it, who had been through that. So when there were complications, it really was just kind of up to my family and I to work through those. And there just really wasn't a lot of support. I think that we've evolved and we've gotten a lot better, including conversations like this. So I think that we're definitely on the right track.
Yes, and there is a nice comment in here about beyond resources. We need more policies in place to ensure the sickle cell community is given the same consideration when it comes to fertility preservation as the cancer community. And along with preservation should come education on preservation options and genetic counseling. We can't leave genetic counseling out of the conversation.
Yes, we just added a genetic counselor to my SC Red team, so we're on it.
Okay, and there are a few questions in about resources. Someone asking for recommendations for SCD mental health group. We have a resource list, a resource sheet that we will be sharing with everyone via email following this webinar. So tomorrow you should receive a list of resources that we have available to share with you all. I'm not sure if it includes an Instagram or Facebook, but we will try to identify that specifically and try to send that along. And then similarly, we have the recording of this webinar. It should be available within the next week, both on the CureSickle.org website and on our YouTube channel. So you will be able to access that. I'm trying to see if there are any more questions. How did or do you balance optimism for a cure, but also recognize the very real risks involved?
I think that's a really good question. that was something that I really struggled with because I come from a family of faith and optimism. And so that was something that was really hard to reconcile, like having faith being positive. And I can tell you that nothing prepared us for the outcome. We were just so sure that it was going to work. And so it's something that even today, as an advocate who, you know, is a part of these curative therapies conversations a lot, is something that I struggle with too. Like, I don't want anyone to hear my story and take it and run with it and assume that that's going to be their experience either. So I think it just goes into managing expectations and understanding that, you know, we're all rooting for you and that we all hope for the best. And so a part of it is just like preparing yourself for the good, but also preparing yourself for maybe the not so good. And it's something that's hard to do for sure.
Definitely. And I see a question in here. This one may best be addressed by Tracy Mondoro about, there's a woman who's asking about the age of people involved in trials. It says it seems that it's only for the young. She's a 58-year-old woman. Is that something that you can address?
Well, I certainly can try to address. I think that when trials are designed, I know that the investigators try to be as careful as possible. And I think also just to let everybody know or remind everyone that the FDA weighs in on these trials as well. And the FDA has certain guidelines where they will accept a certain risk or not. And so I don't know if there's a magic age. I think that's up to, within a trial, there are guidelines which cannot be violated, but for a transplant that's not on a trial, it's a discussion between you and your physician and the rest of the care team. But I think that there's a balance between risk and benefit and age as well. So it's great that warriors are living longer than ever before. And I would also say that NHLBI is interested in other curative options besides gene therapy, gene editing, or transplant. Right now, transplant is the only proven cure for sickle cell. We know people who have received gene therapy are doing well thus far, but it's a very short timeline right now. And we know that there have been some events in some folks where it hasn't gone well, and that happens with all therapies. So we still support research in small molecules. I mean, the dream would be for a pill that you could swallow and sickle cell would go away, but we have to work towards making that very, very safe. So I would just say that people are looking at other avenues of cure besides these kinds that seem very dangerous. And so I don't have a good answer to that question. That was a long answer, but those are all the considerations that go into selecting an age range for a trial.
Thank you, Tracy. And I have another question here. Has there been any research on peer networking for patients considering curative therapy, excuse me, or for those who have gone through the process? I think it would be a good model to implement, similar to having a sponsor.
I am not familiar with any research on peer networking specifically related to gene therapies or transplants, but sounds like a worthwhile avenue to pursue for sure if it doesn't exist.
Great, and then I think this will be the last question before I turn it back over to Tracy. What type of template based on Dr. Hardy's team will help in designing the stopgaps that can be put into place to give clients the time needed?
What sort of stopgap? So what I know we can't follow up with a question, but just trying to make sure I answer it the best I can. What sort of stopgaps could like slow down the process and create space to have these conversations maybe? Is that your understanding of the question?
That sounds right.
Okay. Well, I think that each trial would probably need to consider their timeline separately. I know for a lot of the transplant trials, these conversations begin happening very early on, and they should be having multiple discussions over the course of several months. And so I think we would probably want to think through sort of like how is the rest of the pre-trial phase set up, and looking for ways to sort of incorporate these multiple meetings where these discussions can happen in small chunks over time, to make sure that whenever new questions come up, they can be answered. And education, because we know there's a lot to learn about these therapies, and it's really overwhelming to hear it all at one time, that it's really best to break it up. And so I'm probably looking for those milestones and time points of when they could be best incorporated with the rest of the trial procedures.
Thank you. And thank you everyone on the panel, and to our presenters. I will turn it back over to Dr. Mondoro to close this out.
Great, thanks so much, Victoria. So we want to thank our presenters, our panelists, the sickle cell community for joining us this evening. We know that you're very busy, and so we're glad that you spent the time with us. If you haven't already, we encourage you to sign up on our website to receive updates, and follow us on Twitter and YouTube. And I noticed there was one question in the chat that I retained in my faulty memory. And so, yes, you can be involved in the initiative. You don't have to have any sort of degree to join. And so if you can indicate your interest on the website, then we can talk to you about involvement in the initiative. As Victoria mentioned, the recording of this webinar will be accessible on our website within the next week. And when you signed up for the webinar, you should have received an email detailing gene therapy and mental health resources. And we welcome your feedback or letting us know about additional resources, so that we could consider incorporating those before our next webinar. And I would invite you to stay tuned for more information for our next webinar in 2022, and have a great evening.